So, as you've heard all your medical life, supraventricular tachycardia is a grab bag diagnosis that can mean any narrow complex tachydysrhythmia originating above the AV node. In children, we're often talking about AVRT, or atrioventricular reciprocating tachycardia, down an accessory pathway. But we could be talking about, say, JET, junctional ectopic tachycardia, often due to irritation around the AV node. Or we could be talking about the alphabet soup that spans all of the letters of the alphabet. MAT, EAT, AFib, A-flutter, AVRT in children, AVNRT in adolescents and adults, SNRT, sinoatrial tachycardia, PJRT, or persistent junctional reciprocating tachycardia. Oh boy, all that's great, but just when you need to make micturition rounds, suddenly in front of you there's a toddler crying, inconsolable, maybe a little pale. You feel his brachial pulse. It's fast. You get him on the monitor, and narrow complex tachycardia at 200, 200, 201, 200. Really no beat-to-beat variability to speak of. You have to deal with this now. Your bladder can wait, you think. He doesn't need electricity yet. You'll likely get an IV in him, but that's going to take some wrangling. As the commotion draws in more help, you have a few bedside magic tricks up your sleeve.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. We've talked about SVT in the past, and we can definitely dive right back into it. But today we'll focus on a neglected but often helpful trick of the trade: vagal maneuvers. They used to be all that we had in medicine. Before we had AV nodal blockers or cardiac pads plugged into the wall, sending just enough joules into the delicate cardiac conduction tissues to stun the rogue impulses and get your natural pacemaker working again. With vagal maneuvers, we're going to recruit the parasympathetic system to release acetylcholine. Acetylcholine in the sinus node slows the rate of impulse formation. Now, acetylcholine in the atrioventricular node slows the conduction of the signal, and it lengthens the refractory period. This makes the AV node both less sensitive to the new bombarding impulse, but also it drags out its readiness to accept a new impulse. Doubly helpful. We're trying to slow the signal and not try to change anything about the conduction system itself. Vagal maneuvers don't do anything to the His-Purkinje system, for example. That system just takes orders and carries them out. This may make you think that vagal maneuvers are a total win. And they typically are, especially the patient who's had a renegade impulse that takes over the pacing of the heart. But, like anything in human physiology, it's not all black and white, and there's always a price to pay. For example, vagal stimulation to the atrial tissue itself doesn't slow down conduction of the signal. So if you have a runaway impulse in the atria, vagal maneuvers don't slow it down. They do, however, shorten the refractory period, making the tissue ready faster to accept a new impulse. And that's great when we're talking about the AV node, but it's counterproductive when we're talking about the renegade impulse from the atrial tissue. Now, hopefully you have a functioning, healthy AV node that's a good gatekeeper. Vagal stimulation slows down the conduction in the AV node, and you get the biggest bang for your buck there. The heart rate slows. But since, as we mentioned, vagal maneuvers decrease the refractory period in the atrial tissue, any renegade ectopic foci who have not yet had a go at causing chaos can now speak up and speed up. I mention this because Sometimes our maneuvers or our medications or electricity, they work initially, and then the patient goes right back into SVT. But now it may be for a different reason. There just is no free lunch. Another traitor in this game of fast and loose is the ventricular myocardium. Yes, the muscle that gives us perfusion to our whole body sometimes plays both sides. Vagal maneuvers themselves decrease ventricular inotropy, so the squeeze is less, at least for the time being. Now, if your blood pressure is tanking because your heart is just too fast and that is affecting your diastolic filling, then the answer is to slow it down no matter what. You need to fill the ventricle or it can't pump anything. The downside is that the pump, at least temporarily, is slightly weakened. Usually this isn't a big deal, but it does partially explain why your BP can dip during these maneuvers. More on that in a minute. Vagal maneuvers are great. They're fast, they're cheap, and they're usually safe. We can do all kinds, but we should only do a few. For example, many things cause a vagal response, like carotid sinus massage, Valsalva maneuver, the diving reflex, breath holding, rectal examining, coughing, eyeball smashing, gagging, vomiting or swallowing, jamming an NG tube down, squatting, or Trendelenburg. You've probably already made a mental list of the ones that you want done to you if you ever have SVT. Keep those in mind. Just because we can do something doesn't mean we should. Luckily, there are a few tried and true maneuvers that make sense, have an evidence basis, and don't cause too much pain and anxiety. The type of maneuver you choose will depend on the practicality of the situation in front of you. How sick is the child? How old is the child? Can he or she follow directions? Can you pick him up? We'll go over the maneuvers starting with what typically works for the youngest to the oldest, starting with the diving reflex, the good old upside down baby maneuver, carotid massage, Valsalva, and modified Valsalva. First, the diving reflex, or water submersion reflex. We don't actually do either of these things nowadays, but a modified version of them. Nowadays, we place a bag of ice over the eyes. The diving reflex has been studied for the past 300 years, and we've learned a few things about it over time. The classic diving response in humans happens when the face is submerged in cold water, and the fifth cranial nerve, the trigeminal nerve, sends an afferent signal to the brain sends an efferent signal down the 10th cranial nerve, and presto, parasympathetic activity results. Oh, did you want more? Are you sure? Okay, here's your next witty cocktail party bomb you can drop. The full story is that the sensory nerve endings of the trigeminal nerve send neuronal signals via the Caesarean ganglion to the sensory nucleus of the trigeminal nerve, forming an afferent pathway of a reflex arc. This afferent pathway continues along the short internuncial nerve fibers in the reticular formation to connect with the efferent pathway in the motor nucleus of the vagus nerve. In other words, the trigeminal talks to the brain passes the message to the vagus, and the vagus does what the vagus does, slows things down. Interestingly, in humans, for some unknown reason, the diving reflex works only when the face is submerged, and the bradycardic effect is greater the colder the temp. If the limbs are also submerged in humans, the diving reflex is not elicited. From what I understand, the diving response works because it's a strong, solitary, unique, and kind of shocking, unexpected stimulus. It travels up the afferent trigeminal to the reticular formation, basically your brain's info hub, and then that message is relayed to the vagus. The signal is very strong, it's specific, and it's solitary. We're looking for a quick off switch. So in clinical practice, we want the signal to be received clearly. It's sort of analogous to eliciting deep tendon reflexes. When you strike the patellar tendon, for example, it has to be clear and accurate. If you just slap the whole knee, nothing happens. You need a clear signal. The diving reflex sounds great, but then again, we don't want to drown our patients. Yes, in an adult who can cooperate with you, maybe theoretically you could find a bucket and fill it with ice. Let's be honest, it would be a bedpan, clean preferably, and you could dunk the already anxious person's face into ice water. We all know this ain't happening. We need something simple, reliable, reproducible, and controlled. How about ice bags to the face? It gets the job done. The conventional teaching in children is to make an ice slurry in a plastic bag. So grab your ABG kit bag or specimen bag or anything that you have that can hold water. Ice, add water, seal, and place this over the very tachycardic, regular, and symptomatic child's eyes. In an infant, be careful not to occlude his nostrils. Babies less than 6 months of age are obligate nasal breathers, and you could suffocate him if that floppy ice slurry bag dips over his nostrils. If you do it right, it's magic. You'll see the heart rate go from 180 or 200 to 140, 150 in less than a minute. Going back to our physiology, ideally, the more the trigeminal nerve is stimulated, the better. If we drape an ice bag over the forehead and eyes, we're going to get only the ophthalmic branch, or the first branch of the trigeminal nerve. Why not recruit the second branch, the maxillary branch of the trigeminal nerve? You could get 2 bags of ice, drape one each over the cheek, eye, and forehead, making a little nose sandwich, again, keeping that nasal airway open. That way, you have more of the face covered in ice, and you keep the little nares patent. It would be impractical, I think, to have to juggle another bag of ice on the mandibular branch, the third branch of the trigeminal nerve. Plus, you can definitely start occluding the mouth with that approach. In other words, instead of an ice bag just to the eyes and forehead, increase your trigeminal afferent signal in the diving reflex by 100%. Flank the face with 2 bags of ice slurry. And for our next act, the good old upside down baby trick. It works, or at least it's worth a try. We've known mostly anecdotally or in case reports about this technique, some going back to 1981, that for infants and small children, we can hold them carefully and gently and turn them upside down for up to 30 seconds at a time and break that SVT. Now, even though it's one of those pearls handed down to you over the ages, we haven't had much evidence basis until recently. The research buff in you may scoff at the small number of subjects I'm about to tell you about, in this case, 24, and cringe alert, the p-value in this very small cohort was not 0.05, but we all know that p-values are a terrible way to admit or reject data. Let me explain to you. Il dottore Gabriele Bronzetti è esperto in cardiologia a Bologna. Le aree in cui il buon dottore eccelle sono la cardiologia pediatrica, così come la diagnosi ed il trattamento di aritmie, sincopi, cardiopatie congenite ed il soffio al cuore. Come? What? Oh, sorry. Dr. Gabriele Bronzetti, he's a pediatric cardiologist in Bologna. He specializes in arrhythmia, syncope, and congenital heart disease. His team published an interesting study. They assigned patients to either an upside-down maneuver or standard vagal maneuvers. They found that the upside-down technique converted the child to sinus rhythm in 67% of cases, compared to 33% with vagal maneuvers. For the subgroup that did not convert with the first attempt, when tried again, 50% converted with the upside-down technique and 0% with vagal maneuvers. Now, again, this is a very small sample size. You could even call it a case series, really. But it does highlight the possible ineffectiveness of a small child following directions to perform a vagal maneuver, and you have another maneuver that you can do. In practice, the upside-down maneuver probably works best with small children that you can easily pick up, like infants and toddlers. In the Bronzetti study, they really only tried it in children less than 30 kilos. I would do it for someone that you can easily and comfortably wrangle down. You can try it, but only after telling the parents what you're doing and while you're waiting for someone else to grab an IV kit. To be clear, the Bronzetti study was pre-hospital, but they included children of all ages, and they did the upside-down maneuver in the smallest, in those less than 30 kilos. You could also theoretically have older children and adults do a handstand, but I wouldn't have anyone get on their hands and knees on the ED floor. Maybe it's more of an interesting tidbit, or if you find yourself out of the hospital with your crazy cousin Marcia, who's always talking about her palpitations and she always has to tell everyone about it. Speaking of a little crazy, let's talk carotid massage. The ancient Greeks likely knew about this technique, which was preserved in writing by Islamic scholars in the Golden Age, one of which was the famous Persian physician known as Avicenna in the West, and in the Arabic-speaking world of medicine at the time as Ibn Sina. He's often called the father of modern medicine for his scientific approach to medicine and the way he influenced many other great scholars of the time through his writings in logic, mathematics, philosophy, religion, poetry, and even more. His Canon of Medicine was the medical encyclopedia in the East and the West until the 16th century. Avicenna was the first to describe carotid sinus hypersensitivity and its relationship to vasovagal syncope. Since it's a traditional technique we have used for, centuries now, we know a lot about it. Carotid sinus massage can terminate various SVTs, including AV reentrant tachycardia, AV nodal reentrant tachycardia, sinoatrial reentrant SVT, etc., etc. Cardiologists traditionally have loved it in stable patients to diagnose a rhythm. For example, if you block the AV node with carotid massage, you can see atrial flutter better on the rhythm strip. Also, theoretically, you could try it out on a patient you think has carotid hypersensitivity. You could, make them pass out with it, and presto again, the diagnosis. Oh yeah, and a temporarily unconscious patient. The carotid sinus baroreceptors are innervated by the carotid sinus nerve, which is a branch of the glossopharyngeal nerve of our buddy cranial nerve 9. Those fibers project up to the solitary nucleus in the medulla oblongata of the brainstem. The solitary nucleus modulates the sympathetic and parasympathetic neurons in the medulla and pons, which then regulate the autonomic control of the heart and blood vessels, so a reflex loop. It may not be a big deal in children and adolescents, but anyone who may have any atherosclerotic buildup in their coronary arteries may get a little plaque milking from your massage and end up with a stroke. Now, I hesitate to go on about this, but knowledge shouldn't be held captive. And danger is your middle name, right? I mean, since you're listening to this podcast, I know you can handle it. Here's how you do carotid massage if you dare. Have the patient lie down and feel the carotid pulse directly under 2 or 3 of your fingertips. You have to have enough coverage to make sure you elicit the reflex. You can do the carotid massage on the right or the left, but the left side is more likely to act on the AV node, whereas the right side will more likely act on the sinus node. Anyway, with the patient's head turned away from you, use your fingertips to massage the sinus area for 5 seconds at a time, beginning gently and progressing more rapidly to heavier pressure. You're going just under the angle of the jaw, of the mandible, and on the carotid pulse. If you want even more bang for your carotid buck, you can have the patient in Trendelenburg and Valsalva or hand grip while you do the massage. Again, for only 5 seconds at a time. The hesitation to do this nowadays is, of course, the uncommon but very real risk of stroke in adults, but also really it never was a reliable technique in the first place. Even adults that seem cooperative become uncooperative when you're massaging aggressively. I think it's impractical to use in children because it's very uncomfortable. But maybe you're out in the backwoods and you have nothing else. Sure, but make sure you do it on a young, healthy person. To honor Avicenna and give a more evidence basis, various studies have shown that the order of efficacy in vagal maneuvers is this. The diving reflex is the most reliable, followed by the Valsalva maneuver, followed by carotid massage. One recent review by Collins et al. In the American Journal of Emergency Medicine of all existing literature at the time came to 3 conclusions. First, a therapeutic intervention should only be performed when the benefit of the procedure outweighs its risk and carotid sinus massage can cause harm. Second, a therapeutic intervention should be efficacious, and the efficacy here is modest at best. And third, we have other, more reliable, more reproducible, safer alternatives. Which brings us to the tried and true and the new and improved, the Valsalva and the modified Valsalva. It's named for Antonio Maria Valsalva, also from near Bologna and Imola, but born in 1666. So he would have known all about Avicenna's work. This is the time of Sir Isaac Newton and Johannes Bach. Valsalva focused on anatomy, and mostly of the ear, the eustachian tube to be exact. He describes the maneuver of bearing down in order to open the eustachian tubes to expel pus from the middle ear. But it was later modified to include expiring against a closed glottis to elicit a cardiac response. So the good old Valsalva we know and love is already a modified Valsalva, if you want to be all nerdy about it. Well, we're talking slowing down the heart, not popping your ears. So let's just talk about what happens during the Valsalva maneuver for our purposes. The Valsalva maneuver slows your heart through 2 mechanisms, vagal stimulation and the baroreceptor reflex. Bearing down and expiring slowly through a closed glottis makes your thoracic pressure positive. It decreases venous return, which will decrease cardiac output. So, on the one hand, all else being equal, you would see an increase in heart rate to preserve cardiac output, right? Except no. The 2 mechanisms I just mentioned override and hijack your normal systemic workings. The vagus nerve, cranial nerve 10, is directly stimulated by increased thoracic pressures, so that results in a relative bradycardia on its own. Separately, the baroreceptor reflex in the aortic arch is stimulated and sends a signal up the glossopharyngeal nerve, cranial nerve 9, to the same solitary nucleus, and yes, more stimulus to elicit bradycardia. The baroreceptor reflex helps to fine-tune your blood pressure and heart rate during normal circumstances, but the Valsalva maneuver hijacks it to trick it into thinking your cardiac output is higher than it really is, so it slows things down for you. How do you harness this great power at the bedside? Well, traditionally, you ask a school-aged child or older to bear down. Or in a smaller child, you can try to mimic the Valsalva by placing your palm low down on the abdomen and pushing gently but firmly up to the right rib cage, increasing the intra-abdominal and intrathoracic pressures. I've had more luck with this in adolescents and adults, to be honest. Since asking the patient to do something like bearing down can give you varying results, to say the least, recently most people will give the patient a 10 cc syringe and coach them aggressively to blow out the plunger. Again, you have to be mature enough to follow these directions. Using a syringe, at least, makes this a more reproducible procedure and some endpoint for the patient to aim for. A modified Valsalva has been described, most notably in the REVERT trial. It was a multi-center RCT in the UK to compare the standard Valsalva with syringe to Valsalva syringe and elevating the legs 45 degrees. Long story short, the modified version with leg raise may be better. There are a lot of statistical problems. Other trials have attempted to show something else. No one has really been definitive, but here's the bottom line. Valsalva, we know works. The syringe technique adds a bit more reproducibility, and raising the legs maybe gives you a little more volume bolus, so why not? So that was a lot of particulars. Physiology, history, updates. There are other ways to stimulate the vagus nerve, like coughing or gagging. Surgeons will have all kinds of stories to tell you about the things they try to do to avoid vagus stimulation in the OR, and we could go on about it, but I want this to be practical. The truth is, whatever works safely. Let's bring it all together. Let's get back to our very symptomatic toddler. You guess is maybe 2 years old. You guess is maybe 13 kilos. He's awake, he's very ticked off, and he has reasonable perfusion. You're excited. You turn him upside down before you explain what you're doing, and the mother shrieks. More frenzy in the room. Nurses are coming in. You kind of flinch a little so you don't keep him upside down long enough. You have, remember, up to 30 seconds. Now that the mother thinks you're crazy and the nurses are giving you side-eye, you ask for an ice slurry and you get blank stares. You ask for an IV and you go get the ice slurry yourself. As you're walking into the room with your nicely sealed specimen bags, feeling a little more confident, 2 nurses are holding him while the third pierces his skin with a catheter. A scream, and 200, 190, 180, 170, 160, 160, 160. The SVT broke. So that's my little last tidbit for you. Vagal maneuvers are great. They have their place, but often the IV does the trick. And remember, you always have your best friend, Jules, to deliver a synchronized cardioversion. Start at 0.5 joules to 1 joule per kilo to break the SVT. My take is that it's important to understand the power of the vagus nerve, either as a way to explain the patient's presentation or complaint or how you see them, or to use it to your advantage and help him or her out of a supraventricular tachycardia. Depending on the age, you could use inverted position, just make sure you tell people what you're doing, ice slurry, modified Valsalva, or maybe carotid massage, if you dare. Vagal maneuvers are like the nursemaid's elbow reduction of the heart. If you have a nice, straightforward case and can fix it right away, why not? Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.